Yes, hi, this is Kelleher, and thank you for the opportunity to speak today. I appreciate the work that you're doing and the important work you're doing. But I like, my slides aren't as pretty as they would be if my staff were here to help. And not only that, I think the work that we're doing right now with COVID has emphasized how radical we need to be in thinking about primary care. So I want to run through these early slides and really spend time at the end on things we normally don't talk about in primary care. My goals today are to talk about the who, child primary care and accountable care organization run by providers, what, the trends that we're seeing in primary care, why we focus on children specifically, and how, the things we don't talk about. So who, I want to talk about particular Partners for Kids, which is our ACO for Medicaid enrolled youth. Partners for Kids is 1,900 providers, about 1,500 of whom are primary care physicians in central and southeastern Ohio with Nationwide Children's Hospital. We have about 325,000 children, and it's a 501c3 charitable organization. It will be expanding next year to fully half the children in the state of Ohio, 500,000 children. And for pediatrics, that's a large number. There's nothing like that out there. All Medicaid youth. The funds flow is complicated. Ohio Department of Medicaid contracts with managed care plans to contract with Partners for Kids, and then Partners for Kids pays the medical care providers, and surplus is reinvested into child health programs, and specifically into our housing programs, our employment programs, and our education programs for children, because without these things, our areas of concentrated disadvantage, which are really high-cost Medicaid areas for Partners for Kids, would continue to cost us more in the long run. And I hope we get a chance to talk about that. But the primary care features and aspects of our network, which is about 1,500 practices, really fall into two groups. Those that are contracted with us as core network and those that are non-contracted. And the core group, even within that, comes to us as practices. And I think this is the fundamental challenge in primary care consideration. I've heard it this morning already, the conflicting discussion about whether we're referring to practices or a service. And when we refer to practices and clinicians, we're being clinician-centric or site-specific. And when we're referring to care, we're referring to patient-specific and less site-specific. And that's what we're able to do with our contracted practices as a network, to be a really integrated medical neighborhood such that our children's hospital employed practices, our private pediatric practices, and COPC, a large private group that engages with us, can take advantage of our entire range of services and support so that they can be comprehensive and higher quality. The FQHCs, county health centers, private offices, retailers, and online are all growing rapidly in our area, but they are not currently integrated yet, and it's one of the challenges of network-based practice. But what does happen is quality distinguishes itself, and so what we see, and I'm going to fly through these, they'll be submitted, and they're in the with the committee so they can look at these, but HEDIS measurements, ADHD quality prescribing, utilization of preventive services versus ED and inpatient, they're all better with our contracted practices and improving over time compared to the non-contracted practices, which are actually declining over time. So we see that with our asthma as well. And I'm going to leave you these slides and not spend time on them because we could go over each one in some detail. But our efforts really show that our primary care contracts allow us to act as support services for the practices, because practices, we've done several studies funded by NIH with ADHD, several on depression, and a couple others on asthma, and none of them show primary care practices individually being able to manage longitudinal responsibilities in complex organizations over time. And even the best practices struggle with registry maintenance in multiple different conditions. So I'm trying to be contentious and hope you'll argue with me a little bit on that. But I think really network-based primary care is really the only way that pediatrics will survive in primary care in the future. So what trends are we seeing? Well, our trends are much like you're talking about already this morning. We do have increased nurse practitioners and PAs, and in fact, we are assisting private practices in outlying areas to recruit those people to their practice instead of seeking MDs or DOs all the time. We are exploring pilot peer-based and parent-peer models to support practices and provide support for those families in practices. We're also doing primary care enhancement with specialists using Project ECHO on a growing basis, a very high demand, and quality improvement coaches from the network. So expansion in the number of services that we can offer to the primary care practices as a network. And the location is, of course, expanding as well. The number of school clinics we are conducting for the state of Ohio, school-based clinic development for FQHCs around Southeast Ohio, and doing consultations and setup seminars. We're also offering assistance to retail pharmacies and retail services that want to align with us and integrate medical records and providing more and more text messaging for certain, especially in our Medicaid population. And then, of course, consolidation and corporatization. And consolidation is very hard in pediatrics because large organizations, the very largest hospitals you can name in the state of Ohio and Pennsylvania and Minnesota are buying practices and asking them not to accept Medicaid children because it's not good for the bottom line. So as pediatricians, we're losing our best practices to large consolidation, even though we have an extensive network that covers most of the central and southeast parts of the state. Our practices are being picked off one by one and being told, don't take Medicaid children. So this is, pediatrics, and not just pediatrics, but child health is being subjected to the Medicare advanced funding streams, while Medicaid is being left behind again. Digitalization is happening in self and group care. We could talk about that. We have a number of research projects in that area, but it would take a lot of time to go through those. These are just the trends in the annual change in office visit with increases for NPs and PAs and decreases for our pediatricians. We're seeing this locally. And I wanted to talk about why a special focus on children, so I can really get to the contentious stuff. So children have a different range of visits coming in. The components of preventive care and acute visits are much, much higher. So when we distinguish between pediatric visits and we look at the number of visits that are chronic complex care, chronic conditions, that's much fewer in a pediatric setting. So when the state does CPC Plus or another such kind of funding tool, pediatricians and family practices that see a lot of children get a lot fewer dollars for coordination of care. And that coordination isn't sufficient to hire new staff. So we don't have diabetes coordinators or congestive heart failure coordinators or patient educators that can serve in one single practice. They actually have to be networked. So for example, our suicide prevention coordinator and behavioral health screening coordinator covers 10 practices at a time. And so the idea of providing everything within a medical home versus a medical neighborhood is quite different. Plus, this model, this is a slide from American Community Survey and Child Trends, and just shows that nearly half of children rely on government-sponsored health insurance. And after COVID, I expect this to increase by 10% across the country as we see, a 20 to 30% employment rate that was talked about in the Wall Street Journal yesterday. We're going to see a rapid rise in Medicaid rates, and with so many physicians around the country refusing to accept Medicaid, children will not have access. This is the number of primary care physicians that accept Medicare versus Medicaid, and just the top two slides are Medicare, our top two bars are Medicare and private insurance, and the bottom bar is Medicaid, and this is where our kids come in. And you can see that most non-pediatric physicians don't accept nearly as many Medicaid patients as they do Medicare and or private insurance, and of course, when they do, they cap them. Pediatricians are not much better, and it's not great, but I'll leave these slides. The bottom line here is Medicaid is increasingly less and less accepted by pediatricians, and they have caps on it. So for our network, what we have to do is actually pay extra bonuses for practices to open up their practice to all Medicaid patients. So we actually pay a multiplier when practices join our network to get them to open up their practice, and then we gradually transition that access bonus into a quality bonus over time. So this is what I really wanted to talk about, things that we prefer not to talk about in pediatrics and in primary care in general, and just spend a couple minutes. I don't want to go through individual slides because I don't think they're helpful, but first of all, we ignore in accountable care organizations and in our networks and basically in pediatrics, rural children and access. And we have increasing evidence that children in rural areas have greater rates of developmental disabilities, mental disorders, suicide, a growing rate of problems with a declining tax base and diminishing services. And yet, we have not addressed that in primary care and in pediatrics in particular. And I think we have to do that. Poor children in this country, we're not only not taking Medicaid patients, but in other areas, law, in education, in transportation, in retail, we have said separate is not equal. But for poor children, we are saying it's okay if poor children have a separate system called FQHCs and community health centers, and pediatricians and other private primary care docs don't have to take care of them. Now, it may be in some places that's a great solution, and I know the FQHCs I know with are working really hard, but they're working with poor resources and lots of turnover and not really the care they need, and certainly not the support from the academic centers. So separate does not mean equal, in my opinion. And if we don't address separate and unequal, then we have a problem. Babies and mothers. Primary care has not been involved as extensively. We've handed off the care of maternity care in many ways. And as a result, babies and mothers are getting ignored so that maternal mortality is on the rise. And there are many other reasons for that. But I think that we have ignored the linkage between infant care, maternity care, and what needs to happen there in the communication of data. Managed care companies have maternity data. A network like ours has pediatric data. They're not connected and not shared. That's consistent in many states. I put pediatrics here. I already mentioned the one case where large networks are coming in saying, focus on the Medicare patients, no new Medicaid kids. And we're seeing that also when we try to do care coordination within practices and place our care coordinators with practices. Yes, children do not pay as well. And we are going to have many, many more poor children. And in my mind, this is the great travesty because we know now that the vast majority of adult, early identifiable chronic disease starts in childhood and adolescence. And so if we really want to bend the cost curve, we're going to start to focus on healthier children, but we're missing that point. We already heard people talk about mental disorders, and I put primary care here as things we don't talk about, things that don't matter, because the bottom line is when I talk about this to other institutions and talk about ACOs, all of the major cost savings out of ACOs have so far come out of specialty hospitalization and regionalization. They have not come out of primary care. But primary care access for the most vulnerable matters a lot because that's the main connection to social services in communities. So if we don't set up the social service connection that we just heard about, if we don't have the integration of not practices, but primary care with social services, I believe we're going to miss the boat on this. So what are the challenges? I think we have a failure of a practice model. We've confused practice with primary care rather than a care model, a network, a neighborhood. I think consolidation and contracting are radically altering the focus on high-pay patients rather than and marginalizing children, poor, rural, and minority. And our opportunities are really to have population health goals. So this year, Nationwide Children's Hospitals and Partners for Kids worked with the county and city to set 10-year goals for population health for all the children in the county, independent of whether there are patients or not. Our primary care practices make up 25% of all those patients, but we're going to be working on all 100% of the kids. over the next 10 years. And I think until primary care commits to population health, which is what it's really designed to do, we won't get there. Barbara Starfield was my mentor at Hopkins, and she preached community and care. She didn't preach anything about practice. Improving personalized care for panels, I think we really can personalize this with texting, outreach, and this COVID requirement. We're going to have a major depression with radical increase in the number of Medicaid poor, much lower state and Medicaid dollars in the future per membership, per person, and we have to figure out a way to address that. Thank you.